Welcome to this Give Me 15-minute education program for medical professionals. My name is Jennifer Stearfoss, and I'm the CEO of the Stearfoss Consulting Group. This presentation is part of a series covering the final 2014 Medicare regulations. Specifically, this session will address what you need to know about the final physician fee schedule for 2014. This session is being recorded live on December 11th, 2013. And this session, along with many others, is available for free through iTunes as a podcast or as a video archive on YouTube. Learn more at jenstearfoss.com, including other in-depth sessions on the 2014 Medicare Final Rules. One quick legal note, none of the information contained in this presentation should be construed as legal advice. I encourage you to contact counsel if you have any questions regarding state or federal law that apply to the concepts covered in this session. And with that, let's go ahead and get started. So today what we're going to cover is just a list here. So the SGR, the Doc 6, and Congress. I'll give you an update, which is ripped from the headlines. Brief update on gypsies, which are the geographic practice cost indices, not roving bands of gypsies. And I'll go over three different main items. So the first two are the interim RVU rates, which there were significant changes in the practice expense and malpractice relative value update, along with chronic care management. And there's a couple other policy notes I'm going to toss in here. But we're going to really speed through this because it is a very long rule. So let's get down to business. So as I'm sure you are acutely aware, every year CMS, the Centers for Medicare and Medicaid Services, publishes a final rule on or about November 1, which covers Medicare specifically for physicians, for outpatient prospective payment system, and that includes the hospital outpatient department and ASCs, and those are paid on something called the ambulatory payment classifications. This session is only covering the physician fee schedule. So due to the fantastic and wonderful government shutdown that happened earlier this year, the final rule was released for public inspection right before Thanksgiving on November 27th. It was published in the Federal Register on December 10th. There are a couple formatting issues that the CMS is aware of, but just know that there were some formatting issues in the Federal Register, and that will be corrected. Comments on the Federal Register publication, or actually just the public inspection final rule, those are due January 27th. And I'm going to spike that out because the interim RVU rates in particular are open to public comment since those are interim final. So please, 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 there's a number of significant changes on it. Know that you can submit comments until January 27th, 2014. This final rule, though, does become effective January 1st, even though there's interim final rules, so know about that. And it does affect the entire calendar year. Medicare, because the rule came out late, has extended enrollment decisions until January 31st. Those decisions would be retroactive to January 1st, notably. And if Congress, for some reason, isn't able to act by Friday, they are adjourning on Friday, December 13th, that enrollment decision may be extended depending upon where Congress is standing. So what I wanted to do is just to quickly remind you about this thing called the sustainable growth rate, so we can talk a little bit more about the Doc 6. So if you're not familiar, and those of you that are looking at the screen, I've got the fantastic and wonderful calculation for how Medicare physician reimbursement is determined, which includes the relative value units and gypsies for work, practice, expense, and malpractice, which is all multiplied by a conversion factor. And that conversion factor is influenced for inflation by something called the sustainable growth rate. That has been the ongoing issue for well over a decade in physician reimbursement under Medicare. And Medicare was able to update due to some fluctuations. The original cut that they proposed and also that they sent to MedPAC was estimated to be somewhat higher than the number that they put forward in the final rule, and it had to do with some changes in the MEI, something called the Medicare Economic Index. But guess what? The update is only a negative 20% update, which puts the conversion factor at $27.20 if Congress does not act. So where are we right now? And again, this is updated as of December 11th. So yesterday, December 10th, Representatives Ryan and Murray were able to unveil a 2-year budget framework. The framework really addresses a number of the sequester cuts that were included in that. But notably, there's two things that are missing that are a big deal for us. The first one is that there is no physician fix, nothing addressing the SGR in this budget package, which right now Congress is saying that they're going to have a vote on tomorrow on Thursday. But they also do not prevent the sequester cuts to Medicare payments, which in 2013 was a 2% cut. We will have to wait to see what Medicare comes up with for being that cut, but that looks, again, without additional details, to be somewhat in the same range. So, as I said, the deadline right now is that House leadership has scheduled for adjournment to be on Friday, December 13th. It's a great Friday the 13th adjournment. So there's going to be a lot of work that has to be done over the next several days. What I also can tell you is that there are two bills right now that are under discussion. But let me back up and tell you a little bit about the sequester. If you're not familiar with that, you might remember there was a super committee that was coming forward to address a whole bunch of budget cuts and concerns about the deficit, the federal deficit for America. And they needed to reduce spending by $1.2 trillion. If they didn't do that, then there was automatic cuts that were going to go in place, and that's known as sequestration. That was not achieved. And so right now, again, for 2013, there's a 2% cut for Medicare. And again, I'd anticipate for 2014 it'll be somewhat similar. So where we stand today is that the House and Senate leadership worked over the August recess and most of the summer and fall on a package of bills. And they held hearings and a lot of discussion. But the difficulty, and I'll get into a little bit about this, is the cost of trying to fix the physician fee schedule, trying to fix that SGR issue. There was a meeting that was in early December and, with all of the medical societies and a number of lobbyists, and they acknowledged that right now there's no way to get a long-term fix for fixing the sustainable growth rate in a permanent fashion done by the end of the year. It just would be really, really impossible, especially if they're leaving on Friday. So the AMA and a bunch of other groups have come out and said, you know what, we want a really, really short-term fix. That way the legislative bodies have to come back, convene, and address this issue. So right now the rumor is that the patch is going to be about 3 months. What I also can tell you is that the House Ways and Means and Senate Finance Committee is meeting tomorrow on the 12th, and so they have discussions going on today with the weather. Everybody's flown in and they are back, and then they have hearings that are going to be happening on their two different packages. So it's a really interesting time. There's a lot going on, but let me quickly tell you about these two packages. The first thing to think about is the cost of changing the SGR, moving away from the sustainable growth rate. The estimate coming from the Congressional Budget Office, we call that CBO, dropped from $150 billion to $116.5 billion over 10 years, which is actually a remarkable change, and it had to do with enrollment and a bunch of other changes that were related to that. The issue now is that we are talking in Bs. Normally when we talk in Ms and it's just $1 million, we can find things within the Medicare program to change so that those millions of dollars can be changed. And that the money to fix the SGR, again, when it was back in millions, that was intended to come from the Medicare program. Now that we are in the Bs, now that we're in billions, especially 150 billion, that becomes, or 116.5 as we are right now, with that estimate, that becomes still very, very difficult to find things to cut out of the Medicare program that would pay for $116.5 billion over 10 years. So the biggest issue when we look at this fix is that to pay for the doc fix, there has to be cuts to other parts of the federal government. And so that's where there's a great deal of controversy. And again, there's going to be things that, you know, it could be cuts in government spending for military, it could be housing, it could be education that would pay for this doc fix. And that's where a lot of the controversy has come from. But generally across Congress, there is consensus that this needs to be addressed. It's just how can it be done and how can it be done quickly. So we've got two different bills. H.R. 2810 is going before the House Ways and Means Committee, which does have jurisdiction over Medicare Part B. They're meeting to do a markup of this bill on December 12th. The Senate Finance Committee has something, and again, it's been unnumbered for a number of things, but if you want to check it out, the chairman's mark is posted up on the Senate Finance Committee website, and it's called the SGR Repeal and Medicare Beneficiary Access Improvement Act. And there's, again, a nice overview available. The big things to know about is on the House bill, there's something called the UIP, the Update Incentive Program. And to be honest, it looks mysteriously like the value-based payment modifier that has been implemented by Medicare. It also looks at alternative payment models. Again, a lot of discussion about that, which brings in things like the accountable care organizations, brings in bundling models, other global models. The Senate Finance Committee has slightly different, but notably it has 10-year stable fee updates, so it would be a flat update for a decade, which of course gives a lot of stability to physicians and getting away from this every year we don't know where payment's going to go. It also, again, consolidates quality incentive programs, which the House bill is interested in doing, and looking at these alternative payment models. So notably, where everybody's going is Jonathan Bloom testified over the summer and was looking at, again, that several things needed to happen in looking at Medicare reform, was payment stability, development of new payment models, a differential payment for participation in those models, meaning that there needed to be incentivization of physicians to participate in these new payment models. And that payment needs to be more accurate. And again, there's a lot of discussion about accuracy of Medicare payments. So that's where we are right now with congressional action, which means that honestly there's an entire back dialogue that's going on that influences this wonderful final rule that if you have nothing else to do, it's less than 600 pages. I highly recommend it for nighttime reading. So what are the highlights? The highlights really are that there's a modest update for most specialties, but there are significant cuts to laboratory fees, although it's not as significant as was in the proposed rule. There's also cuts to imaging and pathology. I'll be honest, lab fees, imaging, pathology, those are the favorites of Medicare regulators to cut right now, and we'll talk more about it because guess what, more is coming. There was also in the proposed rule a proposal to cap certain codes at the outpatient prospective payment system rate, which defaulted in most code situations to the ambulatory surgical center rate. That has been delayed for further evaluation. My guess is that we will see this in the 2015 proposed rule that comes out in 6 months. Again, due to the government shutdown, agency staff had to rush coming out with their rule. So other things that were included, GPCIs, the geographic practice cost indices, were also reviewed and updated. Under congressional mandate, they have to review it every 3 years and then do a phased-in implementation. So they are implementing the first of 2 parts for this review in 2014. The second part will be in 2015. It does continue to establish the congressionally mandated with no expiration date, which is a really big deal, the floors for Alaska and frontier states. But the expiration of the unilateral floor of 1.0, that expires as part of that doc fix package on December 31st. So something, again, to look out for and to pay attention to is that there may be some other GPCI changes that are coming forward. If you're in an area that generally has had lower GPCIs without congressional intervention, this is definitely something to pay attention to. So let's talk about the actual impact. There's a listing for you if you're a geek like me and want to go check it out. It's on page 74800 in the Federal Register that was published on December 10th. And again, some of the big highlights here I've highlighted in red here. Pathology is looking at a total 6% cut. And then diagnostic testing facilities are at 11%, with independent laboratories at 5%. So this is Medicare using their data on the general mix of all claims that have been submitted and what they estimate. I will tell you that for individual practices, this is not what we're seeing. And absolutely go and do the analysis of your top codes and again, how your RVUs are changing. So let me get into the interim RVUs. I know we're going to hit time here, but I'm going to keep going. So due to the delayed publication, again, it came out almost a month later than anticipated. The RVU updates are considered interim, so please comment. They're due January 27th to the federal government. And there was major changes to practice expense and also to malpractice. But what I want to do is just give you an example. So the practice expense changes were significant. You can go in and see the direct and indirect data that was used. But what Medicare does is that with the data that's submitted to the agency, usually through specialty societies, AMA, and other groups, they take that data and use information to figure out what is a typical patient. So let me explain briefly what a typical patient is. A typical patient is when you look at the totality of all cases, and it has to be on a case basis. If you look at on a case basis, it needs to be the preponderance of cases. So let's say that you have one way of doing a case, and when they look across everybody, that one way of doing cases is the majority of the time. And again, it's not 50%, it could just be 30%, but everybody else is doing it different because there is no standardization of how medicine is offered for that procedure or service. So this is where it becomes a problem. So I've given the example of 63650, and on the CPT code, which is for lead trial placement, the practice expense data only shows one electrode instead of, let's say, 16 that have been implanted. And because of that typical patient and the way things are being bundled, specifically with the multiple procedure reduction, guess what? That service now is looking at a 75% reduction. So this is a really big issue. I actually received confirmation just from CMS the other day about how this is going to work, and the reason it's working this way is because of typical patient. So the two things I want to spike out is, one, again, comment on these rules and use information and data to show otherwise. But importantly, when you receive those surveys, which are talking about the amount of time that is spent on performing services, requests for invoices, other things from CMS or your medical specialties that are working on behalf of CMS, this is critically important. Respond, and respond with the preponderance of your data. This is going to be incredibly important as we move forward. So in totality, we're looking at over 400 code changes, 18 misvalued codes that came forward from contractor medical directors, and significant changes to reimbursement to physicians. Other changes, there were some new codes added to the 90% equipment utilization rate assumption. There's a list of those codes. Direct and indirect supply cost updates also were changed for a number of codes. Moderate sedation assumptions, and ultrasound updates. This is a big one. Ultrasound, before they were saying it was a stationary machine. Now they have moved to a portable machine, which is dollars on the thousands, to be honest. So procedures that had ultrasound before, guess what, have been slashed because of this assumption. Also, global updates with pre-service clinical time, those also have been changed. So things to know about there. What I also want to just, again, spike out and tell you here is that if you're interested in more information about the interim RVUs, I'll be doing an in-depth session on the rule and getting into those details on a 90-minute call because I can't do it in 15 minutes. Chronic care management. This is, I won't say necessarily a new code, but it is a dramatic change for where Medicare is going. Previously, they really were not willing to reimburse for non-face-to-face encounters. After a lot of finagling discussion and some of the trial that's been going on with chronic care management, CMS has basically stated that in 2015, they will begin to reimburse for chronic care management services that are not face-to-face encounters. It's only for complex patients with 2 or more significant chronic conditions. And in probably, I'd say, the 2015 proposed rule, they will have more detail about that standard of care. So look for that likely in July. So these are the highlights for you. Just some quick other notes. Telehealth, they did expand the geography to HPSAs that are in rural census tracts for urban areas. This is really helpful because, again, when you look at certain urban areas, there might be, again, some rural outside areas that were being affected. So telehealth has been expanded, and that's a really good thing. Also, let me skip down to the therapy caps. This is something that was in that last end-of-year fiscal bill from Congress. They extended the cap for therapy services to apply to critical access hospitals. That's effective January 1. The last thing I want to spike out is just this ongoing trend. Medicare is going to continue to ratchet down individual service reimbursement for services. It's just where it's going. Know the trend is coming. Medicare reimbursement for your office is going to go down. And again, the continuing trend I can point to is that clinical lab fee schedules. Guess what? They want to review that because they feel that there is excessive inaccuracies. And yes, these are the words that CMS is using, excessive inaccuracies in the current clinical lab fee schedule, which, again, pennies on the dollar for a number of services that are paid very differently under private insurance. So know that that's coming. I'd expect, again, to see more of that in the proposed 2015 rule. So with that, just quickly, I've got one question that is available as a question about handouts. Yes, these will be made available for those that are participating live on the conference call. Those will be emailed to you. Additionally, they'll be available on jenstierfoss.com. So with that, I have whizzed through a nearly 600-page regulation, and I hope that you have stuck with me and that you've enjoyed the presentation. For those of you that are listening to the podcast or watching the video archive, please remember to rate this recording on iTunes or YouTube. To receive future notices about upcoming Give Me 15-minute programs or other educational sessions, please sign up at jenstierfoss.com. So thank you for joining me for this 15-minute education program. This concludes the presentation.